There we go. Thank you. Well, good morning, everyone, and welcome to our Thursday morning lecture. I hope everyone is in a safe and warm place right now. And if anyone wants to put their video on, you're welcome to, at least for any discussion. I love talking to people when I can, and not just the screen. So we want this to be as interactive as possible. There are a lot of visuals in this lecture, so hopefully you'll be able to see some of the visual parts of it as well. So again, I'm Gretchen Roe. If I haven't met any of you, I am the program director here at Corewell Health for our Hospice and Palliative Fellowship Program, and I love the topic of interventional procedures in palliative medicine. It's a lecture I gave as a fellow myself and have enjoyed continuing to learn and expand on it each year. So please stop me anytime. If you have questions, I'll pause at different times after different sections to see if there's questions about the section we covered. And I'm also keeping an eye on the chat. So I have no disclosures. Objectives for today's lecture is to explain why interventional procedures should be considered in palliative medicine. We're going to describe indications and risk benefits for common interventional procedures. There's a lot we won't be able to fit in and discuss, but these are the highlights. We'll explain which procedures are preferred for different pain syndromes and identify when neuraxial blocks and infusions could be considered as part of our palliative care toolbox. So we'll start by looking at the prevalence of cancer pain because a lot of the procedures we'll be talking about are for cancer-related pain. In the past 10 years, and I was just researching this recently, the prevalence of cancer-related pain has gone down, which is a good thing. And maybe some of that is related to the fact that people are living longer with cancer, maybe it's detected earlier. So in general, there is a lower prevalence, about 45%, 55% in advanced disease. And I have where I got some of this information below. And the moderate to severe pain in 30%. That all seems so low to me because we're always seeing the people who have intractable pain or we're being referred, whether it's clinic or inpatient. So to me, it feels like 90%, though this is the actual statistics. So it's related to the cancer itself, metastases, treatment itself, or the comorbid conditions that patients have. So it's often multifactorial. Undertreatment of pain is higher for underrepresented populations. So indications for interventional procedures for pain management. Consider these procedures if cancer pain is refractory to traditional opioid pain management, despite increasing medication dosing and adjusting. If your patient is having significant dose-limiting opioid adverse effects, if there's coexisting comorbidities that preclude safe use of opioids, such as opioid intolerance, we mentioned that little point above, but also opioid use disorders being brought out as another reason to think of early interventional procedures. If they've had a prior benefit from a specific procedure, such as selective nerve root block, or maybe they had a celiac plexus block ablation, but it may have worn off over a period of time, then that is an indication that maybe that could be repeated if it was successful previously. So what are the benefits? Why do we consider these and why consider them early? Number one is pain relief. If they're effective, they can have good pain relief. That if there's good pain relief, then we can possibly decrease their systemic opioid requirement and therefore side effects. Those side effects of nausea, constipation, brain fog, respiratory depression. We can improve function, which is always something that we'll be asking our patients about when our pain assessment, how is their function? And we want to be able to not just cover up their pain with opioids, but allow them to function. Improve their quality of life. And we always have that goals of care as part of our assessments and discussions of what do they want to be doing that they can't be doing? What's important to them? For example, I've had patients who want to continue to work, want to be able to drive to work, but don't want to have the brain fog or the side effects from opioids. They have a wedding they want to be at, their child's wedding, a vacation. Maybe there's hobbies that they want to be able to do. So all those things are important and why we move towards interventional procedures. as a part of our treatment plan. There's also reduced medical costs if our patients are not requiring as many prescriptions to pay for ED visits, hospitalizations for uncontrolled pain. So this is a flashback to July when we talked about the fundamentals of pain. So as a reminder, we have different types of pain and different procedures target different types of pain syndromes. So we have the nociceptive pain, the somatic pain, that injury to the somatic tissues, the bones, joints, muscles. That's a more localized pain. We have visceral pain that has that injury, stretch, compression, invasion of these visceral tissues. So that's the bowel, different organ capsules, liver, for example, liver capsular pain, pleura, that's poorly localized. We have neuropathic pain, and that can be peripheral or central, and that can be involved in at least 40% of cancer pain syndromes. So as we know, it's a lot of mix. It's often a mix of all these types of pain for our patients. So what we're going to be doing is talking about different types of blocks. So I'll start with sympathetic blocks. We'll move to more peripheral blocks, and then we'll talk about neuraxial blocks and infusion, which is your epidural and intrathecal delivery. Throughout this lecture, I'll be sharing any evidence, and I share the article where we got all this information about certain procedures and their level of evidence. So as I do that, you can see what is the 1A mean. So if someone's a 1A, so there's an evidence level 1 through 3, 1 being the best evidence, the most robust, controlled randomized clinical trials, down to 3 is more expert opinion, descriptive studies. And then they label as a letter, so A, B, C, D, or I, A being the most recommended, where D down to D is inadvisable and I is insufficient data. So not every procedure I mentioned will have a classification, but if there is, I will share that. All right, so we're going to start with sympathetic blocks. The big thing to know about sympathetic blocks is it is used for visceral pain. So visceral cancer pain is when the afferent input traveling along the autonomic nerves, which is sympathetic or parasympathetic, that is involved in the pain. The sympathetic nerve blocks interrupt these afferent fibers, but they also concurrently block the sympathetic efferents. That can lead to some of the side effects of diarrhea or the static hypotension due to the unopposed parasympathetic activity, and that's usually transient, 2 to 5 days. So some background to know about it. Let me go back to that last slide. You can see, well, actually, I have better slides about showing how this is done, but a lot of these are CT guided, so you'll see a lot of CTs, and I'll point out some things as we go along. So sympathetic blocks, they can be CT, MRI, fluoroscopy, or ultrasound guided. The most that I see that are done are CT guided, at least here at our institution. It's a 2-step process, the first being the prognostic therapeutic nerve block to say, does this work? Are we in the right spot? Is it effective? And this localizes that afferent pathway involved in transmission of pain. It's usually a combination of a steroid, or first of all, a local anesthetic, such as bupivacaine or ropivacaine, as well as a steroid. Decadron is the most common. The steroid potentiates the effect of that local anesthetic. And especially if there's an inflammatory component, it can really be beneficial. The local anesthetic works maybe up to 8 to 12 hours on the high side, sometimes less, 6 or less. And it's the steroid that kicks in about 2 to 3 days, and that can give it a longer lasting effect. So if someone has a block, but it lasts for weeks, that's the steroid that's kicking in and helping. So our interventional team will check in, usually if they're outpatient, 24 to 48 hours, or inpatient as well, to see how did it work. If there was improvement of 50% or more, then they consider that a success. It's important if you're rounding on your patient in the hospital or calling to follow up on your clinic patient, to ask how was that pain, how was the pain improved in that first few hours afterwards, or first 6 hours, how was that time? Because their pain could have returned back by the time you call them or round on them in the morning. So just really make sure you're asking about that time for the hours after the block. All right, and step 2 in the process, if it's effective, is a therapeutic neurolysis. So that's where we're destroying the afferent neural pathways and sympathetic structures involved in pain transmission, knowing that the block was helpful. There's a couple ways to do that. There's the chemical neurolysis. Often what's used for that is a very potent, strong alcohol or phenol, or there's a thermal way. You can do radiofrequency ablation or even cryoablation. Different risks involved with sympathetic blocks. You can get a neuritis, phantom pain from deafferentation pain, from neuroregeneration. There's that side effect of the diarrhea we mentioned that can be transient and transient hypotension. So those are some common side effects. I think the diarrhea is the main one that I've seen patient experience. I haven't had the neuritis in any that I've seen. I like to show this diagram because I haven't found anyone I like better to show sort of where those different ganglia complexes are along the sympathetic tract. And the main ones that we'll focus on are the most commonly used ones, the celiac plexus, hypogastric, and ganglion impar. So one of the favorites is celiac plexus block. The celiac plexus block is used for upper abdominal malignancies that are associated with visceral pain. The plexus is near that level of T12 to L1, and that plexus innervates most of the abdominal viscera. Oftentimes, we mainly think about it with pancreatic cancer, but it actually could be used more broadly because it innervates anywhere from the distal third of the esophagus all the way to the mid-transverse colon and all those organs that you see here listed on the slide. So it, as my tip says here, I add some extra tips. It's a higher success rate compared to other sympathetic blocks. So consider this one early and often. The evidence level is 1A, so great evidence for pancreatic cancer-related moderate to severe pain that's been refractory to analgesics, or for your patients who can't tolerate opioids. The other little pro tip I have is that if your patient is being followed by GI, which often happens in pancreatic cancer, they've gotten scopes or other things. Many GI docs can do a celiac plexus block and ablation, and they often do it at the same time, which is nice, while they're doing the endoscopy. So it's ultrasound guided. They're right there. They're very close to it. And so that can be a great way to save your patient from going through additional procedures. And sometimes they've already had an upper GI, but I'll reach out to the GI physician to say, could you get them in for a celiac plexus block? So sometimes you don't catch them when they do their initial endoscopy, but they're oftentimes very willing to schedule that. So it's either GI or an interventional pain specialist that can do this procedure. I have some visuals here showing, my pointer over here, where the celiac plexus is, and you see it's laying right over the aorta. So I'm personally glad I'm not doing these procedures, but it is very close to aorta, so risky, but I think they've perfected this technique to get this done really safely and well. That's why it's CT guided or image guided. There's a posterior approach here in this CT image, or there can be an anterior approach where you see a needle here, and they inject dye first around the area to make sure that they're in the right spot before doing the block or ablation. So I mentioned a little earlier some common side effects, the diarrhea, orthostatic hypotension, and then the rare side effects of pneumothorax and other things listed here. It's contraindicated in bowel obstruction and coagulopathy. And again, just consider this for malignancies of the upper abdomen. The other time that it can be, I've seen it helpful, not in all cases, but as chronic pancreatitis, those refractory upper abdominal pain from chronic pancreatitis. So when all else is not working, it could be something to try. So if the celiac plexus is not plexus block is not affected, but you think it really should have been, man, that's the pancreatic cancer, or it's pain right there, it should have been effective, then consider a celiac plexus block. That, as we can see here in this figure, the splanchnic nerve block is, the splanchnic nerve plexus is very close to the celiac is here. The splanchnic is up a little bit higher, so very close. And sometimes the tumor, maybe it's a pancreatic cancer tumor, is blocking the proceduralist from actually getting to the right spot. And so this splanchnic nerve block could be a next step to consider. Its level of evidence is 1B for pancreatic body and tail cancer. All right, we're moving down further to the superior hypogastric block. This plexus is located on the anterior surface of the aorta, level of around L5S1. It innervates these areas, the descending colon, rectum, uterus, bladder, and prostate. So consider for intractable visceral pelvic cancer-related pain. The can have mixed results. And the main reason why when I talk to the proceduralist is because it's just sometimes harder to get to compared to the celiac plexus block. And sometimes I'll have people who have a positive and a good result from the block, but the ablation is not effective. I'm like, why would that be? I think it's really hard to get that concentrated alcohol in the right spot. And maybe it was easier to get the local anesthetic and steroid in. So it has to just make sure it's dripping and contained in the right area. So, and it's in the retroperitoneal space. So evidence is 2B for this particular block for pelvic pain that's refractory to medical management. Similar side risk and side effects of the orthostatic hypotension, diarrhea that can be transient, injuries to any of things around that area as well. The other thing to think about why these aren't always as effective is people who have pelvic cancers. There's not always just visceral pain, because this will only help with the visceral pain, but there's pain that's somatic from sacral or muscle involvement, or neuropathic pain from nerve root compression. So that could be another reason why this is maybe a mixed result. So I usually tell patients when I'm referring for a procedure, I'm hoping that this at least takes a piece of your pain away. And sometimes it's a stepwise process. Well, let's take this piece of your pain away, and maybe there's another procedure we'll take a different piece of your pain away, but not to have the expectation that this is going to solve all their pain. So again, it's a diagram or visual figure here of where the needles go, how they access and get close to that spot, and here onto the right where they inject the dye to make sure they're in exactly the right spot where they want to go. All right, and down further is the ganglion impar block. This is where the sympathetic chain comes down to a solitary ganglion. It's unpaired, it's retroperitoneal, near the level of the sacrococcygeal junction. It's used to treat visceral pain in the perineal area. So all these areas listed here, from distal rectum to vulva, perineum. So consider its use for cancer in the lower rectum, anus, distal third of the vagina, rectourethral fistula, radiation proctitis, and intractable perineal pain. This also can have more mixed results given the retroperitoneal location. It can be hard to get to the exact spot. Evidence is 3B, but consider in that intractable perineal cancer-related pain. And here is where, so exactly where that sympathetic chain ends here, the impar ganglion. So I'm adding in a peripheral nerve block here just for comparison, because oftentimes when we're looking at impar block, we're thinking, well, would a pudendal block work? And that's a peripheral nerve, but this is what I've heard from proceduralists, when to use one versus the other, when they consider one versus the other. So in perineal pain, the pudendal block is actually most effective for perineal pain if it's more superficial or anterior. And the impar ganglion block is better for deeper, more posterior pain. Some patients need both to get the best pain control, because these perineal cancers that involve that area is just so painful, so debilitating, and impacting quality of life. So sometimes they're done at the same time, but most often it's like try one and then go to the next one if it's the first one's not working. All right, so now we're doing the lumbar sympathetic block. So the lumbar sympathetic chain is a paired ganglia near the L2, L4 vertebral bodies that gives innervation to the lower extremities. So there's a lot of interesting things, and I'm reminded every year about places where I could probably consider this when I haven't. So like one is tumor-related bladder spasms. I had a patient recently that they were so challenging to control, and I forgot to think about this block. It's helpful for tumor-related lumbosacral neuropathies, that are very common. Groin testicular pain, some vascular vasospastic diseases of the lower limb, which can be difficult also to treat. Phantom limb pain. And then also invasive tumors around that lumbar plexus itself. Similar to other sympathetic blocks, you could have some hypotension with it, change in temperature to the ipsilateral leg, and some neuralgia as well, potential side effects. All right, I will pause here and see if anyone has questions on sympathetic blocks. I don't think I see anything in the chat. So if not, I will move on to peripheral nerve blocks. So this peripheral nerve blocks can be really helpful for the somatic pain, localized pain. Peripheral nerves can be impacted by the compression or invasion of primary tumors or metastatic lesions, or from degenerative disc disease, wounds, chest tubes, thoracotomies. So a lot of different things can impact our peripheral nerves. So they can be used for somatic pain within a distribution of a particular nerve or plexus. It can be used in combination with other therapies. It can be a single injection or continuous infusion, and we'll talk about what that would be like. The risks are neuritis, or another significant one is motor or sensory block, which is why these tend to be a block and not an ablation. It's more of a temporary measure to get someone through a painful period of time. I'm going to start with my favorite. Why is this my favorite? Because it's very effective, predictably effective. And so similar to when I think of a celiac plexus block, I think of it early. I don't wait till everything else has failed or I'm on high dose opioids. Consider this early and often. So when can these be helpful? For lung or breast cancer with local extension, metastases to the chest wall and ribs, rib fractures, chest wall trauma, post-herpetic neuralgia, post-mastectomy or post-thoracotomy pain syndromes, chest wall wounds. So really anything around the chest wall or affecting the pleura even. It's usually ultrasound or fluoroscopy guided. The first step of the block, and this can also be a two-step procedure. If some people just have a block or a continuous infusion in a certain area, and then some, if it's going to be extended, like breast, like a chronic wound or post-thoracotomy syndrome, this is going to be long-term cancer eating away the chest wall, then having it doing a block and ablation, it makes the most sense, the block being the test. So they use a bupivacaine often as the local anesthetic plus a steroid like Decadron. Risks that are common to anything that you're doing around that area is infection, bleeding, pneumothorax. These photos are from a particular case of a young woman who had breast cancer, had mastectomy, a big wound, was at home trying to do twice daily dressing changes, really crying, screaming in pain because of how severe those dressing changes were. She had young children, did not want to have her children see her in this severe pain. So looking into options. So what she had was first a block, the intercostal block of 4 levels, which is the top picture here. And this, you're seeing the dye injected to make sure they're in the right spot. And that alone lasted about 3 weeks. So that was that steroid really kicking in. And then there was a cryoablation of the nerves of all 4 levels. That's a photo of that. They call that the ice ball with the cryoablation. And that was months, lasting months. So it probably could last even more, but the last she was tracked, it was months of relief. So that really is like numb that whole area up. So just to be able to take that pain away, improve quality of life, and not have to just give a bunch of pain medications hoping that will do something, it was so encouraging to see. So consider early and ablation can be considered if a longer pain relief is needed. So continuous infusions, these are often used in the inpatient setting. I haven't seen them myself outpatient, but there could be pain physicians who do that. But what they are, and this is just an example, I have no ties to a certain company, but I just like to give you a visual. This is one type of pump where there's a continuous flow of a local anesthetic for targeted pain relief around a nerve or nerve plexus. It can stay in for a maximum of 5 to 7 days, so it's limited. That each bulb in this particular type of one lasts 2 to 3 days because it's filled with the medication, and then there's a flow rate that's adjusted. An example of when this can be used is a serratus catheter for rib fractures. It can be used for continuous infusion around a femoral nerve for a hip fracture. So really any nerve, an anesthesiologist, that's the team that does it at our hospital. We have an anesthesia pain service that does a lot of post-operative blocks and sometimes infusions. They will do it after rib fractures or thoracotomy there's ongoing pain. And the proceduralists will always ask us, so what's the end games? Because if it's cancer-related wall pain, this is only going to give you like a week of pain relief. So instead of doing this, I'd say let's get the block and ablation because that's going to set them up for success for longer. Whereas if it's just post-op pain or something that may get better in a shorter period of time, then these blocks are very effective. They're also nice because people can be discharged home with that catheter in place and they can be given instructions on how to pull it out. So that is nice. So there's newer brands too. I'm just going to go back for a second. They didn't get pictures of the newer brand that they're using at our hospital, but the newer one actually has a PCA function where patients can control it. I don't know if they're necessarily using that, but there's a lot of new ways and technology for this to be delivered where patients can even get little boluses intermittently on top of the continuous infusion. So I think there's involvement of what these things can do. So the rector spinae plain catheter is another one that's helpful for that post-operative pain that the anesthesia pain type of teams can place, and also good for rib fractures. If epidural is contraindicated, maybe they have low blood pressure, other reasons they can't have an epidural post-op, this can be a different way to control pain. And where they put it, if there's thoracic versus upper abdominal pain, will determine where they put the catheter, whether the upper thoracic spine or the lower thoracic area. So that's just a tissue plane. So there's the local anesthetic is not in this one tiny area, it sort of spreads in this tissue plane to provide pain relief. This is also a great one, the fascia iliaca compartment block. It's very effective for pain around the hip. So, for example, we'll have maybe a hospice patient even come in after a hip fracture, wants to be evaluated in the ED. Maybe they don't want to have surgery, maybe they do. either way, having a block here, which most ED physicians now can do ultrasound guided blocks, they can block that area with bupivacaine. At least it gives them several hours of pain relief. Sometimes then a follow-up to that, if an anesthesia pain service is at your hospital, they could do a continuous infusion around that nerve area to give them more days of pain relief. And that can be really helpful, especially if they're not getting it fixated, which could improve pain, or they're elderly and can't tolerate a lot of higher doses of opioids to give pain control. Brachial plexus is a little more complicated. I mean, it may be used for tumors involving brachial plexus or upper extremity. The main thing is it can, a lot of procedures shy away from it because there's risk of motor blockade. If someone's not ever going to be able to use their arm, then maybe that makes more sense for those patients. But it could be used as a temporary measure with a block, but rarely any kind of ablation. But depending on where the pain is determines where along that whole track of nerves you will block. All right. Well, before we move to our next section, does anyone have any questions on the peripheral nerve blocks that I've brought up so far? All right. Well, we'll keep moving on then. So the next one we're going to talk about is cancer-related bone pain. So very common in metastatic disease. We know that radiation therapy and some medications that inhibit osteoclasts may help reduce pain as well as adverse skeletal events. But radiation may have some mild immediate benefit, but usually takes several weeks to start having an improvement in pain. So what we can consider is, and it's not to replace radiation, but really some of these interventional procedures can be done at the same time, sometimes even before. And I usually encourage, if I'm considering recommending an interventional procedure for a patient, having the interventionalist talk to the radiation oncologist to make sure the timing and they're all coordinating well. So this interventional procedures may give more immediate pain relief while waiting for that radiation to kick in and work. Also, some procedures will say it's even better to do the kyphoplasty, for example, first, because once someone has radiation to their spine, the vertebral bodies are more porous, and that cement that they put in may leak out and be more likely to leak out. So there's some maybe benefits to doing the interventional procedure first. So different options are vertebroplasties or balloon kyphoplasties, which is pictured here, where there's height loss, the height's restored with the balloon, and then cement is placed in that spot for stabilization. There also can be, with metastases to the spine, a radiofrequency ablation, which is burning, or cryoablation, freezing of the tumor area, followed by some cement placement to give that stability and structure. What I've learned over the years is that cement is added in areas where there's weight-bearing structures. Because one time I asked for a radiofrequency ablation and cement for scapula metastatic lesion, and they started laughing like, oh, it's not weight bearing, so we don't really put cement in those areas. So I'm like, all right, now I know. So really the spine, the pelvis are areas where they add the cement. And I really think that the cement part of it is what gives the more immediate pain relief, and because there's stability and to that. And I'll have some case examples of how quickly people can have improvement in pain. So good news, evidence is 1A for these vertebroplasties, kyphoplasties, and strongly recommended for patients with symptomatic vertebral compression fractures from spinal metastases. All right, so here's the case I'll tell you about. So I had very memorable a case where a 67-year-old female had a newly diagnosed parotid gland adenocarcinoma with metastatic disease involving L5, sacrum. She had been, before being hospitalized, which is where I saw her, she was limited to the prone position, literally laying face down on the bed for weeks. Severe piercing pain in her lower back and legs despite these medications. So by the time I did my consult, they were asking for cordotomy. I'm like, whoa, let's back up and see what else we can do before a cordotomy. But that's how debilitated and how poor her pain is, and how poor her quality of life was at that point. So after having our interventional team get involved and evaluate, she ended up having a couple procedures. She had an L5 radiofrequency ablation with kyphoplasty and bilateral sacral ala radiofrequency ablation and cementoplasty, so in the pelvic with the pelvic fractures. It led to significant improvement in her pain within 24 hours. I remember walking into her room after seeing her just face down. I had to sort of like, sit a certain way. I had to talk to her in those other days. She was sitting on the edge of her bed. So I was just like, whoa, what is going on? Sitting on the edge of bed, talking to me, smiling, so happy. And I think she was able to get up and walk with a walker a little bit after that. She was able to end up discharging, I think to Trillium Woods actually, and just was able to enjoy some time and just ended up going forward with hospice, but with a much improved quality of life. So it was so awesome to see just how immediate you can get relief with these procedures. So here's some images from her case, particularly there's some destruction of the L5-S1 area. There was intraoperative balloon inflation here for the kyphoplasty and then cement placement here. And then for the sacral fractures, this is the probes they are using here for the radiofrequency ablation, and then they added the cement. All right, so we'll talk a little bit about lumbar pain, because we have a lot of people with lower back pain. It may be related to cancer or metastases, it may not, because a lot of times we're seeing patients for their cancer-related pain, but they also have degenerative disc disease and that sciatica that we're sort of managing all of their pain. So some common procedures that are done for back pain, again, for cancer or not cancer-related reasons, are epidural steroid injections. Indications are degenerative disc disease. They could have patients who have continued pain despite their vertebroplasty, pathologic fractures that aren't really amendable to vertebroplasty or ablation. They can have up to 3 injections at intervals of less than a month apart. So if they space them out, they could have more than one injection. Typical risks of doing a procedure in that area, like infection, bleeding, dural punctures, all pretty rare. So it's really common if someone has bilateral pain or midline pain, that's usually when they go to the epidural steroid injection. Versus another common one is a selective nerve root block. Typically that's used when there's that one-sided unilateral radicular pain going down a leg. That's when they tend to do the selective nerve root block versus that more epidural steroid injection location. These can last months with often it's a local anesthetic and a steroid. And again, it's that steroid that gives that longer effect. And it can be repeated in a few months if it's the pain comes back. So this is one of those, like, if it worked before, it could really work again for a patient. Medial branch blocks are also talked a lot about. They're helpful for pain related to osteoarthritis of the facet joints, pain with those lateral movements of the neck or back, or worse when someone has spine extension. It's the local anesthetic delivered to that medial branch of the dorsal ramus that innervates that facet joint. It's a 2-step process. There's some diagnostic blocks under fluoro and local anesthesia. Usually insurances require 1 to 3 blocks that show success before they'll cover the cost of the ablation, but that can last several months. So it can be very effective. Up to 70% of patients show improvement for several months. All right, so that's sort of the bone pain in the back pain section. Any questions on those? All right, well, then we'll move on to central neuraxial blocks and infusions. So the central neuraxial block, you may have heard the term targeted drug delivery. So that is your epidurals and the intrathecal delivery of pain medication. So here you can see here in this figure, the epidural space where epidurals go versus the subarachnoid space, which is where intrathecal delivery is. So we'll start with epidurals. There's a higher fluid volume with the epidurals. Typical risks include respiratory depression, urinary retention. So because of the urinary retention risks, many patients end up needing a Foley or Flomax while they have it in. You can have orthostatic hypotension, so low blood pressure could be a reason that can't be used, and we need something else, like some other type of block that we mentioned earlier in the lecture. The doses are 10% of the IV dose of morphine. We don't really calculate that, but just more for your awareness is why I have all these equivalencies. Sometimes they're board questions about if you have IV versus epidural versus intrathecal, what is the difference in equivalencies? And so that's why I have that outlined here in red for those board exam takers to have in mind. But usually the person managing intrathecal pump is the one who's calculating exactly what to do. So don't worry that you'll be needing to do calculations if you refer for any of these things. So duration, usually epidurals are in to 7 to 10 days before they need to be replaced or removed. The cool thing is if your patients in the hospital who have epidurals, which we see them with people delivering babies, but we also see them post-operatively as very common that we may be involved with because we're not delivering babies. And so post-op, we'll have someone who they have patient-controlled epidural anesthesia, so patients can give themselves a bolus in the epidural, and those are managed by anesthesiology. When can we consider them for our hospice patients? I will tell you a story of a patient. He was young. He had a peritoneal carcinomatosis, GIST tumor, malignant bowel obstruction, just a lot of symptoms. We were escalating opioids. He was probably on a Versed infusion as well. He really wanted to stay awake and alert till his kids from college could get back and see him and say goodbye. And so we call anesthesia. And at first I got a little pushback, oh, what? Epidural, it's hospice patient. But I talked him through, I said, we really need to look at all our options. And so he ended up getting an epidural and had good pain relief from the epidural so that we could go down, not completely off, but we went down quite a bit on his opioid infusions so he could have that period of alertness and to be with his family. So in the inpatient setting, don't rule out the use of epidural in your comfort care patients when appropriate. All right, intrathecal pumps. There's some parts of the country where intrathecal delivery medication is used a lot more than others, just depending on who's able to manage these pumps. So yeah, I'll go to conferences and there's some teams that are referring very early and often, and there's others that aren't. I think we could be using it a lot more, but we do need to think about it earlier because sometimes by the time we're thinking of intrathecal pumps, the patient is very advanced in their illness and may not have a lot of time left and weak and just doesn't want to go through a lot of procedures. So this is intrathecal delivery is medications delivered directly into the CSF in intrathecal space, really in close proximity to those nociceptive afferent fibers right around the spinal cord and the dorsal horn. So some common medications used are morphine, hydromorphone, adjuncts, bupivacaine and clonidine sometimes are added depending on what else is going on. Benefits being decreased opioid use overall, because it's more potent, it's concentrated right in that area rather than systemic throughout the whole body. And a big one is decreased peripheral side effects, the nausea, constipation, those other things that we get with the systemic opioids. The placement of the intrathecal catheter is where it's placed is depending on where the pain is. So just for idea here, that for abdominal pain, it's usually placed near T6 through T8, or pelvic pain, it's T9 through T12 area. There's different risks with intrathecal pumps. There's spinal cord, could be spinal cord damage, spinal headaches, epidural hematomas, infections, catheter migrations, or catheter tip granulomas, but those are pretty rare. It usually starts with a trial, a test dose. So almost like you're getting a lumbar puncture, like a test dose. And if it's successful, it can be followed by a pump placement. The tricky thing about intrathecal pumps, which is why maybe a lot of us don't refer, is it's confusing, like who does these? What's the steps? It's just a lot of coordination. And so I think that's the biggest limiting factor of using it. For us, we've had in the past, our interventional team will do the test dose. And if that works, well, first we talk to someone who could manage it. We have someone in the community who manages intrathecal pumps, so making sure they're a good candidate, then get the test dose, then neurosurgery places the pump. So a lot of coordination. But we have a newer group in town, which I'm going to share contact information later, that does all the steps. They do the test, they do the implantation at a surgical center, and they manage it. So I will share all that information to hopefully encourage you to consider referring for someone to be evaluated for this early. So some of the tips, when do you think of this? If your patients have refractory abdominal or pelvic pain, their OMA is over 200, well, that's like, I feel like a lot of our clinic patients. So we need to think of it before it's 500, 1,000, like these high OMEs that we can quickly get to. Intolerance of systemic pharmacotherapies. Really, that one major criteria is life expectancy, at least 3 months. Really to get cost savings, and there's research to show cost savings after 6 to 7 months. You actually save costs for a patient. But insurance reasons, they have to have life expectancy of at least 3 months predicted. Doesn't always happen as planned, but here you can see in the figure where that catheter is hanging out here. The pump, I meant to bring a little pump, but I know we don't have in-person people anyway, but the pumps are, there's different sizes of pumps depending on how much volume they're going through of the opioids. So you have a bigger pump or a little bit smaller pump, but it's implanted in the subcutaneous area here on either one of the sides of the abdomen. So the patients usually are quite thin with going through cancer, and so they can usually see that pump, but it can work very well and improve quality of life. Spinal cord stimulators. We'll talk a little bit about that because there's quite a bit of that use as well. So the delivery of electrical stimulation to the dorsal epidural space to inhibit the sensation of pain. It's really helpful to set expectations for functional goals to determine if the trial is successful or not. And usually it's a trial with the pulse generator external, and if it's helpful, then it's implanted as a second step. So consider spinal cord stimulation is considered, if someone has neuropathic origin, it can be better than an intrathecal pump sometimes. And radicular pain syndromes, intractable chemoradiation-induced neuropathies, complex regional pain syndrome, post-thoracotomy pain syndromes, phantom pain. So, for example, if I start, let's say, post-thoracotomy pain syndrome, often my first recommendation or step is an intercostal nerve block and ablation. If that doesn't work, this is often the next step that you go to after that. Evidence is level 2. There's actually a lot of levels of 2. So there's a 2-3C for refractory cancer pain and a 3C for chemo-induced peripheral neuropathy. And this leads here that you can see each dot is a separate electrode that can be controlled. So there's a lot of things they can do to control, and they sometimes take several weeks to figure out how much, what settings to go on for the spinal cord stimulator. So just quickly, there's a case, metastatic rectal carcinoma, had chemo, surgery, radiation, didn't want to do any more treatments, pain to the ribs, and then there's from metastases in the pelvis due to lymphadenopathy. There's a couple different procedures that were done, an intercostal nerve block and ablation, effective. There was a lumbar sympathetic nerve block for left hip and leg pain, which was not effective. And then the next step was a spinal cord stimulator trial, which led to 70% pain relief. So they want to get at least 50% or more of relief. And so when to move forward with this spinal cord stimulator placement and then the patient had ongoing improved pain. So just an example of how different blocks can be combined, and it's often more than one thing based on where their cancer and pain is. We won't get into a lot of detail, but it's good to know that there are neurodestructive procedures. This is also probably an underutilized procedures because we're not thinking to refer. So if someone has refractory pain despite other things that we've done, and they have a limited life expectancy, refer to a neurosurgeon that does neuro pain procedures, and let them evaluate and see what other options do we have. We mentioned a cordotomy. Sounds like something that's in the past or like a really old procedure. Well, it's helpful in certain reasons. So it has a radiofrequency lesion to this lateral spinal thalamic tract. That reminds me of medical school. Whenever I talk about that track, I can visualize all my diagrams. It helps with uncontrolled unilateral nociceptive cancer pain after failure of more conservative options. Evidence levels 2B is pretty good. There's the punctate midline myelotomies, helpful for midline visceral pain. So those pain that is not getting better after all your ganglion blocks, for refractory pain, for pelvic visceral pain. Evidence level is 3C. Something called the dresotomy procedures. Not as much evidence, but when all else fails, you want to look at all your options in your toolbox. They may consider this, which is destroying some of the central portions of the dorsal rootlets and horn for neuropathic malignant pain in the limbs. So that's just something to be aware that's out there. So some take-home points. Consider interventional procedures for intractable pain in your palliative patients. And the interventional procedures can provide pain relief, decrease opioid requirements, decrease side effects, improve their function and quality of life. I have a slide here, and you guys will get access to all these slides. If you're in West Michigan, different people who are doing these procedures, and I know there's more. So these are the ones that I know of and utilize. So there's an interventional radiology that is, I know they see more than Corewell because they're more of a private group. And how to refer I have in here. They take Epic orders, and I show how to refer there. If not, there's fax. I have a phone number here. And then there's a Corewell Health Spine and Pain Clinic. They have a variety of different doctors with specialists. They do a lot of spine procedures. They have anesthesiologists. I think they have that holistic approach. They have a pain psychologist. They have, Kayla, you mentioned, do you have PMNR doc? They have someone who evaluates pain and determines did they go to a proceduralist? Do they go to physical therapy? So they do a very comprehensive approach to pain. They do not do intrathecal pumps there. They do spinal cord stimulators though. Haven Spine and Pain is a newer group in town that they can do a lot of these procedures. They're two anesthesiologists. They can do the whole intrathecal pump test, implantation, and management from my knowledge. They can do spinal cord stim, other procedures as well. So there's a variety of ways to get a hold of them. They're very collaborative and responsive. So wanted to share that with you. Also, my book recommendation, if you would like something for your fellowship bookshelves, maybe it's one you keep in the office. It can be a little pricey, so we have it in our office here that people can look at. But it is a great book that talks a lot of algorithms. So if you have this kind of cancer pain, this is what to think about. So just a fun one to go through different syndromes and stepwise approach to treatment. So just giving you just a sneak peek of what's in this book. And then I have several references if you are at all interested in that. All right. So any questions?
Always great talk, Gretchen, and it's so good to be reminded of this, and so I appreciate you presenting this. It really isn't a question. It's just you talked about your memories of the diagrams when you hear the word spinal thalamic tract, and it gives me PTSD. Quite frankly, when I hear those phrases and do things on the neural pathways. But I thought it was great, and appreciate the references at the end in terms of just where we can get those resources. And I think it's just really the more we remind ourselves of these resources, the more likely we are to use them. And I think that really is the biggest challenge that we have, is that if our training has not, if in our training we've not had regular access to this, or have seen our patients utilize these resources, we just don't think about them. And so this is just, a challenge to, well, not just the fellows, for sure the fellows, but for the attendings as well, just to make sure that somewhere in our consciousness, we have to move from subconscious to conscious, that these resources are viable, and particularly for those who practice in the hospice field, I think sometimes we negate them automatically on the basis of price. And we really need to make sure they're on the table as a consideration. So that's just my comment for all to keep those in mind.
Yeah, that's great. I think, and you don't need to know exactly what one to say, oh, I want you to do this procedure. I mean, sometimes once you get to know them, you can be more specific, and it helps the process go faster. But you can just, now that you have an idea what's out there, what can be, you're going to think to actually just make that referral, make that call to an anesthesia pain service if you have one, or to an interventional pain team, and say, please evaluate and see what you think. And then they can go from there. But at least you know what's out there to at least make that referral.
Exactly. Yeah, we don't send someone to with seizures to a neurologist telling them what we want them to give them,
right?
Or send them to the oncologist and say, would you please give them this chemotherapy?
Mhm.
We rely upon their expertise, knowing that they're available to help with that.
Correct.
Oh, I don't know what you guys are talking about with this whole spinal thalamic tract thing. I mean, that stuff just excites.
Did I even write it wrong? I should have a neurologist on here.
No, but Gretchen, I wanted to thank you for the reminder between blocks and infusions as well. So oftentimes we think, oh, let's just go do the nerve block, or especially with the hip fractures, the fascia block. But having the infusion can really provide a lot of that pain relief for a much longer time, especially patients with limited life expectancy or things of that nature. I do think that's one thing we need to keep aware of in our toolbox.
Mm-hmm. And I'll tell you that when I started this as a fellow, because I wanted to give this lecture, I did all this research, found different procedures. Our interventional team was doing celiac plexus block, was the only thing they were doing of all the things that at that point that I brought to their attention. They're like, but we want to learn. And then since that time, they had hired more people who were getting trained in these procedures. So don't be discouraged if wherever you're working, they have a limited procedure, because a lot of these newer, younger people coming out of fellowships can do a lot of the fancy newer things, and they're so excited to do it. And their favorite patients are our palliative patients. So they often drop everything to do things for our patients. We'll have people come from hospice and they'll they'll take them and do an outpatient quick thing, come back. So this brings them the proceduralist quality of life to care for these patients. So yes, continue to advocate and help your hospitals and services grow in these areas.
And then how much of this are you doing inpatient versus outpatient? Do you see a role for this more in one area or the other?
Yeah, good question. I really in both. I'd say the inpatient where we're doing the most is intercostal blocks, ablations, and the sympathetic, the ganglion blocks. If they're there, I'm like, let's get at least the block, and then they can follow up with ablation because it could delay. Our interventional team is a little delayed due to the volume that they have. So if the block was successful, they could always get the ablation as an outpatient. But getting just the first step is great. Outpatient, the spinal cord stimulators, intrathecal pump, that's probably going to be outpatient, more referrals that you're doing. But any of those ablations and blocks, intercostal, those can all be referred from a clinic setting too.
Thanks.
Hey, Gretchen, this is Ryan Stringer. I just had one question about the idea of using an epidural. Do you know if anesthesia has ever pushed that limitation on 1 week to 10 days on the epidural? Like if you have a hospice patient that is really getting good relief, that you're like, can we just leave it in? It's working.
Yes.
Has that been something you guys reach for?
Yes. We try to help them stay out of their narrow window of that and say risk benefit. So sometimes it's been extended in those circumstances. And there's one time when that was all that worked for a patient. We thought she was dying, and then she kept, she was improving so much with it that we ended up doing an intrathecal pump with her. She discharged home. This was a while back. But yes, they will usually extend it beyond that a little bit. All right. Well, thanks for listening.